Welcome to Updates in HER2 Testing in Breast Cancer. The objectives of this presentation are to review the Focus 2018 update in HER2 testing in breast cancer and the application of the updates through case-based scenarios. The course overview is as follows. First, we will give a general overview of HER2 testing. Then we will go through HER2 analysis by immunohistochemistry, FISH, and CISH. Last, we will end with case discussions and a summary. This is a brief history review for HER2 in breast cancer. In the 1980s, Slaman et al. Identified that HER2 gene amplification was associated with worse clinical outcomes in patients with breast cancer. In the late 1980s, they described that the HER2 protein overexpression might be a potential predictive tool for clinical use. Results published in 1996 of a phase 2 clinical trial showed that Herceptin monotherapy was effective in patients who failed prior chemotherapy. This was done in 46 patients with extensive metastatic breast carcinoma that overexpressed HER2. There was an overall favorable response rate of 11.6%. 14 patients obtained stable disease, which lasted for a median of 5.1 months. In 1998, Herceptin became FDA approved for the treatment of metastatic breast cancer. Some HER2 basics. HER2/neu is a membrane tyrosine kinase protein that's encoded by the HER2 gene located on chromosome 17. The cytoplasmic portion of the HER2 receptor is constitutively active when overexpressed. The HER2 gene is amplified in about 20% of breast cancers. HER2 is both a prognostic and a predictive marker for breast cancer. HER2 is a prognostic marker in that it indicates more aggressive tumors with a high risk of metastasis. Patients with HER2 positive tumors have a decreased overall survival compared to patients with HER2 negative or non-amplified tumors. Of course, those tumors are associated with worse clinical outcomes in the absence of therapy with drugs like Herceptin or trastuzumab. HER2 is a predictive marker in that it predicts likelihood of responding to HER2 targeted therapies. There were some early issues with HER2 testing. The Hercept test antibody clone and those clones used in the clinical trials were not the same. Hercept test was not evaluated in a clinical trial before its FDA approval. There was only a 79% concordance rate with clinical trials assay scores. For roughly the first decade of HER2 testing, there were no guidelines on either standardization of pre-analytic factors such as fixative type, length of fixation, or cold ischemia time, or the interpretation and reporting of HER2 status. In 2007, the ASCOICAP guideline recommendations for HER2 testing in breast cancer were published. The goal of these guideline recommendations was to improve accuracy of HER2 testing by developing an algorithm specifying specimen handling, assay exclusion, and reporting criteria while defining positive, equivocal, and negative value ranges. Different methodologies were indicated for detection of HER2, including immunohistochemistry, fluorescence in situ hybridization, and bright field in situ hybridization. Guideline recommendations also touched on variables in HER2 testing, including pre-analytical, which includes fixation time, length, and type, analytical, which has to do with equipment calibration, assay validation, training and competency of staff, antigen retrieval and reagents, and post-analytical, which deals with interpretation criteria, quality assurance procedures like lab accreditation and proficiency testing. The initial ASCOICAP guidelines for HER2 testing were updated in 2013 to add guidelines on tissue handling procedures, or pre-analytical variables. These included cold ischemia time, which should be minimized at less than 1 hour, fixative or suggested fixative, which is 10% neutral buffered formalin, minimum duration of fixation of 6 hours, and maximum duration of fixation at 72 hours, since we know over or under fixation can lead to erroneous results. A recommendation was also added that fixation time points need to be documented in pathology reports. Scoring has evolved over the years, starting with FDA criteria, or those included in package inserts, continuing on through the initial 2007 ASCOICAP guidelines, with updates in 2013 and 2018. First, we'll talk about immunohistochemistry for HER2. In immunohistochemistry, the actual HER2 protein is the target. HER2 is a transmembrane tyrosine kinase, and IHC detects the overexpression of the protein. HER2 IHC results are evaluated as a degree and intensity of membranous staining pattern. The methodology for IHC includes antigen retrieval, incubation of tissue sections with primary antibody to the HER2 protein, the application of a visualization reagent, which is a secondary antibody, the addition of an enzyme-specific substrate, and the conversion to a Brown reaction product by that enzyme. The result of this methodology is a membranous staining pattern. Tissue handling requirements include that multiple specimen types can be used, ranging from core biopsies to resections. Cold ischemia time, which is defined as time from tissue removal to its placement in fixative, should be less than 1 hour. It should be fixed in 10% neutral buffered formalin for 6 to 72 hours. Validated protocols should be used for testing, and labs should show a 95% concordance rate with an already validated test. IHC interpretation is as follows. An IHC score of 0, which is a negative result, indicates no staining or incomplete staining that is faint or barely perceptible in less than or equal to 10% of tumor cells. An IHC result of 1+, which is also negative, indicates incomplete membrane staining that is faint or barely perceptible in greater than 10% of tumor cells. An IHC score of 2+, which is an equivocal score, indicates weak to moderate complete membrane staining in greater than 10% of tumor cells. An IHC score of 3+ or positive indicates circumferential, complete, intense membrane staining in greater than 10% of tumor cells. The 2018 focused update to the ASCOICAP guideline recommendations for HER2 testing discuss some rare immunohistochemistry staining patterns. These patterns are considered equivocal and warrant additional testing. Some examples of these patterns include moderate to intense IHC staining in greater than 10% of tumor cells that is incomplete, either basolateral or lateral in location. Another example is circumferential membrane staining that is intense, but occurs in less than 10% of tumor cells. Again, for both of these categories, an equivocal score should be rendered and additional testing should take place. Here is an example of the first caveat, which is classically seen in micropapillary carcinoma. Please note the intense membrane staining occurring in the majority of tumor cells, though in a lateral or basolateral pattern, would warrant an equivocal score and further testing. Tumors with equivocal IHC results, so a score of 2+, should have reflex testing on the same specimen with an alternative test, such as CISH or FISH, which we will discuss in a moment, specimen using the same or an alternative test. Indeterminate results are also positive for HER2 immunohistochemistry. If technical problems do not allow reporting of a positive, negative, or equivocal result, these results would be indeterminate. Some reasons for indeterminate results include improper specimen handling, crush or edge artifact, and analytical phase testing failure. If any of these occur, additional tissue should be used for testing. Immunohistochemistry for HER2 has both pros and cons. Some of the advantages include the fact that the assay is relatively inexpensive and easy to perform. IHC uses conventional bright field microscopy, where results are evaluated in the context of the histologic morphology. Slides can be stored because staining is fairly permanent, and the HER2 protein is what is actually detected by immunohistochemistry, which is the direct target of some HER2 therapies like trastuzumab or Herceptin. Some disadvantages of HER2 immunohistochemistry include pre-analytical variables significantly affecting results, such as cold ischemia time, fixation time, and type. The fact that different commercially available antibodies can have different sensitivity and specificity, which is less of an issue today with automation, and potential discrepancies in pathologist interpretation, which is hopefully remedied in large part through the ASCOICAP recommendations. Fluorescence in situ hybridization, or FISH, employs fluorescent probes that bind to nucleic acid sequences with a high degree of sequence complementarity. In HER2 testing, there are several FDA-approved assays. There are single probe assays that assess only HER2 copy number, and there are dual probe assays that assess HER2 copy number and a second probe that hybridizes to a reference point, commonly the centromere of chromosome 17, so that a HER2 CEP17 ratio can be calculated. Dual probe assays are the preferred methodology by the ASCOICAP recommendations. Per the 2018 ASCOICAP guidelines, in situ hybridization group 1, which is positive, includes invasive carcinomas that have a HER2 average copy number per cell of greater than or equal to 4.0 and a HER2 CEP17 ratio of greater than or equal to 2.0. ISH, or in situ hybridization group 5, which are the negative tumors, include invasive carcinomas that have a HER2 average copy number per cell of less than 4 and a HER2 CEP17 ratio of less than 2. This diagram shows the location of the HER2 FISH gene on chromosome 17. HER2 gene is located at 17q12.1 on the long arm of chromosome 17, noted here on the diagram on the left as red dots. Green dots signify the centromeric portion of chromosome 17, which is often used as a control in situ hybridization. The picture in the middle indicates a nucleic acid sequence on DNA with a complementary strand labeled with a fluorescent probe. The picture on the right shows 2 chromosomes, each with a normal single centromeric portion of 17, showing HER2 gene amplification with multiple signals on each chromosome. These are pictures of 2 invasive breast cancers. The one on the left shows a HER2 non-amplified tumor. You can see within one nucleus, there are 2 or 1 signals for CEP17, which is green, and 2 or 1 signals for the HER2 gene, which is red. The picture on the right shows a tumor with HER2 amplification. Within the nucleus pictured in the center, there are 3 signals for the centromeric portion of 17 and multiple clusters and single signals for the HER2 gene in red. So what do we do with some uncommon in situ hybridization signal patterns? This was an area of review in the 2018 focused update, with the classification of these less common in situ hybridization patterns defined as in situ hybridization groups 2 to 4, as identified in dual probe. In situ hybridization group 2 are tumors with a HER2 CEP17 ratio of greater than or equal to 2.0 and an average HER2 copy number of less than 4 signals per cell. The in situ hybridization group 3 are tumors with a HER2 CEP17 ratio of less than 2.0 and an average HER2 copy number of greater than or equal to 6 signals per cell. In situ hybridization group 4 includes those tumors with a HER2 CEP17 ratio of less than 2.0 and an average HER2 copy number greater than or equal to 4, yet less than 6 signals per cell. This picture illustrates an example of an in situ hybridization group 4 classified tumor. This tumor has a HER2 CEP17 ratio less than 2 and an average HER2 copy number of greater than or equal to 4, yet less than 6 signals per cell. This result requires correlation with immunohistochemistry to arrive at the final HER2 status. The red probe labels the HER2 gene and the green probe labels CEP17. In situ hybridization patterns 2 through 4 require HER2 IHC correlation. These in situ hybridization patterns require concomitant IHC review for dual probe in situ hybridization groups 2 to 4 in order to arrive at the most accurate HER2 status designation as either positive or negative. So these tumors should have a combined interpretation of in situ hybridizations and immunohistochemistry. Immunohistochemistry versus FISH. The Breast Cancer International Research Group performed a study looking at 2,600 women in a prospective Herceptin-based clinical trials. When results were compared between local and central laboratories, there was 79% agreement between local IHC and central FISH. There was 77.5% agreement between local IHC and central IHC. And there was 92% agreement between local FISH and central FISH, indicating that FISH provides a more reproducible result. Like immunohistochemistry, fluorescence in situ hybridization has both pros and cons. Some advantages of FISH include the fact that formalin-fixed, paraffin-embedded specimens are used for evaluation. No frozen or fresh tissue required. Results of FISH are more objective and quantitative than immunohistochemistry. It is thought that pre-analytical factors such as fixation time and cold ischemia time have less of an impact on FISH as compared to IHC, as DNA is more stable than protein. Some disadvantages of fluorescence in situ hybridization include the fact that it is a more time-consuming and more expensive assay than immunohistochemistry. FISH requires expensive equipment like a fluorescent microscope and staff trained in the assay, performance, and evaluation. FISH signals fade over time, so there is no long-term storage or ability to review these slides in the future. There is a greater potential to miss intratumoral heterogeneity if not thoroughly evaluated. We will touch on this more in a future module. Morphology can be challenging under a fluorescent microscope. The observer needs to ensure that the proper areas of the tumor are assessed and that the areas evaluated are indeed invasive carcinoma. There are multiple bright field in situ hybridization methods, including chromogenic in situ hybridization, or CISH, silver enhanced in situ hybridization, which is CISH with S, gold facilitated autometallographic in situ hybridization, or goldfish, and bright field double in situ hybridization. First, we'll talk about HER2 by CISH using a single probe. In this methodology, HER2 gene copies are recognizable as intranuclear brown chromogenic reaction product signals. The slides are counterstained with hematoxylin, much like we see with immunohistochemistry. The evaluation of chromosome 17 can be performed on a consecutive slide using the same protocol. A high level of HER2 gene amplification will either be shown as numerous individual peroxidase positive small signals, as you see in frame A of the picture on the slide, or large peroxidase positive intranuclear signal clusters, as you see in B. No amplification is seen as 1 to 2 signals per nucleus, as seen in C, or 2 to 4 spots in a case of chromosomal aneuploidy, as seen in D. There is also HER2 by CISH utilizing a dual probe assay. This allows for simultaneous visualization of the HER2 probe and the CEP17 probe on the same slide. 2 different probes are utilized for the HER2 and CEP17 using a hematoxylin counterstain like single probe CISH. Amplification is visualized typically as large DAB stained clusters or by many dots in the nucleus. Examples of HER2 amplification are shown in the picture on the right. In A, we see peroxidase positive clusters of gene copies, and in B, we see multiple individual gene copies. No amplification would be seen as only 1 to 2 spots per nucleus. Here is a side-by-side comparison of non-amplified and amplified HER2 dual in situ hybridization. On the left, this non-amplified tumor demonstrates only 1 to 2 signals per cell nucleus, black. The slide on the right shows multiple clusters and single copies of HER2, also in black. HER2 amplification by CISH is interpreted as small clusters, which can be counted as 6 signals, and larger clusters that can be counted as 12 signals or more. A single nucleus may have multiple small clusters, multiple large clusters, combination of large and small clusters, or clusters and single signals. Do not count cells if nuclei are overlapping, if no signal is present, including the CEP17 signal, if only signal of one color is present, or if signal is outside of the nucleus. This slide discusses concordance rates between CISH and FISH. A study in 2002 showed concordance between CISH and FISH to be 100% in 62 cases tested. Another case in 2002 demonstrated concordance between CISH and FISH for IHC scores of 2+ and 3+ in 100% of cases. 38 cases were examined. A systematic review in 2019 compared the sensitivity and specificity of HER2 CISH when compared with reference testing FISH. This looked at a total of 32 studies. For CISH with an S, there was a 91% sensitivity and a 97% specificity. For single probe CISH with a C, there was a 97% sensitivity and 99% specificity. And for dual probe CISH with a C, there was a 98% sensitivity and a 98% specificity. As you can see, there is a significantly higher sensitivity for dual CISH than CISH with an S. Again, there are pros and cons for chromogenic in situ hybridization. Advantages include the fact that it is a practical and simple assay. It is less expensive and has a faster turnaround time than fluorescence in situ hybridization. CISH permits the observation of morphology because it uses a bright field microscope. Therefore, the simultaneous evaluation of histomorphology and copy number alterations are evaluated, reducing the risk of analyzing a non-malignant compartment. Tumor heterogeneity is promptly recognizable. Slides can be stored and used for re-evaluation or retrospective studies. And dual color assays can be performed on a programmable automated slide stainer, improving assay efficiency and reducing the risk of error. Some disadvantages include the fact that a single probe assay does not allow the determination of the HER2 CEP17 ratio and therefore the detection of chromosome 17 polysomy. The evaluation of HER2 gene copy number can be difficult in cells with high-level amplification because overlapping dots lead to formation of signal clusters. And some samples show high background debris or loss of signal, thus are non-interpretable, though this occurs relatively infrequently. Invasive micropapillary carcinoma is described in the WHO 2012 book on breast tumors as an invasive carcinoma composed of small, hollow, or morula-like clusters of cells surrounded by clear stromal spaces. These tumors have a proclivity for lymphovascular space invasion, and patients frequently present with axillary lymph node disease at the time of diagnosis of the primary tumor. Picture illustrates a good example of a micropapillary invasive breast carcinoma. You can see infiltrative nests, epithelial cells, which are present inside of cleft-like spaces simulating lymphovascular invasion. These tumor clusters are present in morula-like structures as well as in structures containing a central hollow lumen. Nuclei display moderate nuclear pleomorphism. This picture illustrates immunohistochemical staining for HER2 of an invasive micropapillary breast carcinoma. Note that the brown staining is present in a predominantly basal or basolateral distribution. While this staining pattern would have previously been classified as a 1+ or negative tumor, in this instance, these tumors are best scored as 2+ or equivocal, and further testing is warranted. Here is a closer view of immunohistochemistry for HER2 performed on an invasive micropapillary breast carcinoma. Note the dark yet incomplete membrane staining present in the basal and basolateral portions of tumor cells. So as all pathologists know, morphology matters. Consider discordant immunohistochemistry in FISH in micropapillary breast carcinomas, and remember that these cases should be treated as equivocal or 2+, warranting further evaluation. Another caveat is to note HER2 overexpression in a breast cancer phenotype that is usually negative, invasive lobular carcinoma. The 2018 ASCOICAP HER2 guidelines have a key recommendation for pathologists with respect to invasive micropapillary carcinoma. HER2 immunohistochemistry that is intense but incomplete or basolateral or U-shaped that would normally be considered 1+ may be HER2 amplified when using FISH, as was the case that I just showed you. Pathologists should consider reporting these specimens as equivocal and perform an alternative testing methodology. This recommendation is based largely on a single paper from 2013 with a series of 23 micropapillary carcinomas considered 1+ by her CEP test that showed HER2 amplification in one case, which is 4% of all tumors tested. The breast group at Cleveland Clinic sought to evaluate this possible discordance between immunohistochemistry and FISH in a series of invasive carcinomas with micropapillary features that had both immunohistochemistry and FISH testing performed. They looked at 31 cases with micropapillary features. 22 of these were core needle biopsies and 9 were resection specimens. They looked at one representative slide for each tumor. The percentage of micropapillary features on the overall tumor volume ranged from 30 to 100%. These tumors were all Nottingham grade 2 or 3, with 13 and 18 in each category, respectively. Overall, in their series, 16 of 29 tumors, or 55%, were ultimately called HER2 not amplified, while 13 of 29, or 45%, were designated as HER2 amplified. 6 of these 13 that were ultimately amplified by FISH had a corresponding Hercept test of 1+, making up 46% of these tumors. Immunoreactivity included weak staining either along the apical border or along the periphery of the morula clusters without lateral staining in 3 of 6 cases, or 50%. The remainder of cases with a 1+ immunoreactivity had weak lateral staining and staining along the periphery of the morula clusters. This atypical staining pattern is highlighted in this morphology, with 6 of 13, or 43% of cases with micropapillary features and HER2 staining that would otherwise have been scored as 1+ being amplified by FISH, although there were low levels of amplification. While these results were likely biased toward borderline cases, if this discrepancy was borne out in larger series, the potential for dual testing with IHC and FISH for carcinomas with micropapillary features seems appropriate. The take-home message being these cases should be considered 2+ or equivocal with additional testing by FISH or CISH in order to ensure patients are able to receive the treatment that they need. Though the vast majority of invasive lobular carcinomas are HER2 negative, there have been reports in the literature of HER2 positive invasive lobular carcinomas, including this report by Yu et al. This picture demonstrates an invasive lobular carcinoma with tumor cells infiltrating as single cells and in single file pattern with bland nuclei and intracytoplasmic lumens. This is a picture of a case of invasive lobular carcinoma HER2 immunohistochemistry. You can see here that the tumor cells show complete dark membrane staining in the vast majority of cells, indicating a positive or 3+ result. This is an H&E slide of another invasive lobular carcinoma. This case demonstrates tumor cells infiltrating as single cells and in single file pattern, with very small nuclei and scanty cytoplasm. No significant nuclear pleomorphism or mitotic activity is appreciated. This picture demonstrates HER2 IHC in this same case. Here you can appreciate dark staining of the tumor cells. However, it is difficult to interpret whether this staining pattern is truly membranous due to the small size of the tumor cells. When evaluated using CISH, you can see confirmation of HER2 amplification by the large clusters and single HER2 signals seen as brown. There is a good internal negative control in this picture, which is the benign duct in the center, where you see a lack of HER2 amplification. Any atypical staining pattern should always raise a red flag for pathologists, including intense membrane staining for HER2 in invasive lobular carcinomas. It is appropriate to follow up these cases with additional testing such as CISH or FISH. So what have we learned in 20 years of HER2 testing? First of all, the definition of HER2 positive has been a moving target. Thankfully, guidelines put forward have been dynamic documents that try to encompass the relevant literature as it becomes available. HER2 testing and results reporting has changed slightly with each ASCOICAP update. The 2007 guidelines sought to eliminate false positive results, defining IHC 3+ as positivity in greater than 30% of tumor cells with a HER2 CEP17 ratio greater than 2.2. The 2013 update sought to capture everyone that was positive, lowering the threshold for IHC 3+ to greater than 10% and the HER2 CEP17 ratio to greater than or equal to 2.0. I would say the 2018 focused update hopes to better identify those who will benefit from treatment, focusing on unusual signal patterns seen in FISH.